Hi, everybody. Welcome to another episode of The Heart of the Matter. I'm joined by my wonderful colleagues, Bourann and Ankit. Today, we are going to be talking about the rapid CABG study. So, this study is the overall theme of it is that they investigated whether a coronary artery bypass surgery 2 to 3 days after ticagrelor cessation was non-inferior to waiting 5 to 7 days and incurring perioperative bleeding. So that's the overall, but I'm going to go into it a little bit more. So ticagrelor is a potent reversible P2Y12 antagonist, and it's a guideline recommended drug for acute coronary syndromes. So, per the Plato trial, ticagrelor is frequently administered prior to coronary angiography, before the coronary anatomy is defined and decisions are made for revascularization in ACS. But more than 10% of patients with ACS actually end up requiring a coronary artery bypass graft surgery. So, the key concern for patients receiving the ticagrelor is the severe perioperative bleeding leading to mortality, because platelet transfusion, specifically for ticagrelor, platelet transfusion cannot reverse the antiplatelet effects. It does, as a drug, have a faster offset time compared to other P2Y12 inhibitors, such as clopidogrel. This potentially allows a shorter period between the cessation of the drug and getting the CABG. But the thing is that platelet quiescence is important in these situations. It's a concept where the potent antiplatelet inhibition with the dual antiplatelets that we often use, like aspirin and clopidogrel, or aspirin and ticagrelor, this actually often reduces, or we think that it reduces the mortality among patients with acute coronary syndrome requiring a CABG. So this is why actually we would like to further consider earlier CABG after the ticagrelor cessation, because of the faster offset time. So right now, the guidelines for patients getting a CABG after receiving the ticagrelor vary, but there is a suggested waiting period of a minimum of 3 to 5 days before surgery. These recommendations, though, have always been solely based on pharmacodynamic and retrospective study data, and also based on assumptions about platelet recovery and decreased bleeding time. But in this study, they sought to evaluate whether early CABG surgeries at 2 to 3 days after ticagrelor cessation is non-inferior to waiting 5 to 7 days and incurring perioperative bleeding, among specifically with patients with ACS who require non-emergent CABG. Earlier surgery could decrease the ischemic events, but there is some obviously concerns of increased bleeding. But ultimately, the hypothesis is that an early surgical strategy is non-inferior for incurring severe or massive perioperative bleeding. So now I'm going to go to Bourann. I'm going to pass it over to her to talk a little bit about the study design and the methods.
So, yes, this study is multi-center, which really just means two centers in Canada. It was open label and it was a randomized non-inferiority study, as Anisha mentioned, with a total follow-up of 6 months for this particular study. So, the patients that were included in this study are those at least 18 years of age who presented with ACS, received ticagrelor, and underwent coronary angiography. They then would be referred for CABG post coronary angiography. And patients were eligible if they were less than 48 hours from their last ticagrelor dose, and then within 7 days of the original diagnosis of acute coronary syndrome. Now, this did exclude any patients who had stenting for a culprit lesion that was identified during the coronary angiography, anyone who needed concurrent valve surgery, and then, of course, anyone who required emergent CABG, because the benefit obviously would outweigh whatever risk they're incurring by having them being on the antiplatelet therapy. And that goes as well for the initial stenting with a culprit lesion, as those patients do, need to be on antiplatelet therapy at minimum. for, 30 days post PCI. Um, and so that's how the study was designed. The primary endpoint was class 3 or class 4 bleeding, um, which was determined by this universal definition of perioperative bleeding. Um, Sort of chart. Class 3 bleeding is designated as severe, and class 4 bleeding is designated as massive, and those are the most severe classes. And there are like clear criteria within them of what they consider to be severe or massive bleeding. It's primarily determined by the presence of or decision for delayed sternal closure, for post-op chest tube output, like significant output, the use of blood products. And so the specifics of that, depend on each class, but the idea is that the most severe classes of bleeding are those where there may have been delayed sternal closure and that there was at least a liter of chest tube blood loss within 12 hours and potentially the use of blood products. So that was our primary endpoint. Um, and the non-inferiority margin that they used in this case was 8% difference between the groups. Now, there was a secondary endpoint that they used as well, which was 12-hour chest tube drainage. Um, which is also a component of the primary endpoint, but is separate, separated out here. And that was also a non-inferiority endpoint, and they used a margin of 25%. There are some other endpoints, secondary ones, that they assessed, some for superiority, but it appears based on the way that the results are written for this, that they were not able to prove superiority in any of these, and that also the sample size was relatively small. And for the amount of patients that were in this study, I believe it was somewhere in the 140 something patients to that effect. So it is small. But actually, the point of this study originally was to be a pilot study for hopefully later larger studies where they may be trying to prove superiority. So that's why, one, the margins are on the wider side, and then also why it's a small group of patients. So that's how the study was designed. And then Ankit is going to talk about the results of the rapid CABG trial.
Yep. So importantly, some basic surgical related characteristics before and after surgery. Those are pretty much very similar. An important thing to note as well, there are about 20% of women in both groups, which are evenly distributed as we would expect. So going to the results, there were no differences in the bypass times, the on-pump times, or the amount of chest tubes placed. As Bourann mentioned, the primary endpoint was the severe massive perioperative bleeding, which occurred in 3 out of 65 patients in the early group and 3 out of 58 patients in the delayed group. So the p-value for that was 0.03 for non-inferiority, which met the non-inferiority margin. The other one was the median chest tube drainage, which was also very similar between both groups and met the non-inferiority margin or p-value of 0.01. As Bourann mentioned, there were other secondary bleeding outcomes that were assessed. For example, like BARC 4 or 5 bleeding, the use of cryo, FFP, and other transfusion products that were not significantly different between groups, but were trending a little bit higher on the early group. And then they did do an evaluation of ischemic events as well, and this was at 6 months. And then they had a composite, which was MACE, that included death, non-fatal MI, recurrent angina, and unplanned revascularization, which was lower in the early group than the delayed group. It was 5.6% in the early group compared to 13% in the delayed group. But again, the study was not powered for these outcomes. And of note, the ischemic outcomes were largely driven by recurrent angina in the delayed group as well. So not more of those, a little bit more of a subjective endpoint. And then lastly, comparing length of stay. So the ICU length of stay was similar, which we would expect post-CABG, but the overall hospital length of stay was significantly shorter in the patients that had early intervention. So overall, coming back kind of to the overall outcome of this study, it showed that early CABG, 2 to 3 days after Brilinta use versus delayed CABG, 5 to 7 days after Brilinta use, was not inferior regarding their post-operative bleeding risks, and it was not powered to evaluate some of the secondary outcomes and ischemic events. So now going into the discussion, we kind of talked about Brilinta and how it's unique in terms of its reversibility compared to the other antiplatelets. Um, we were talking a little about this earlier as well. Brilinta has a little bit of a longer half-life. The active metabolite, I think, lasts 12 hours, and the drug itself lasts 9 hours. Um, which makes it a little resistant to platelet transfusion, especially if it's reversible, it's just going to bind to another platelet, as opposed to some of the other ones, although it hasn't really been proven that platelet transfusion has worked for Plavix, at least. The other thing, which we talked about several times during this whole discussion, was that this study was small. It was a pilot study and was significantly underpowered to detect some of these major differences in bleeding and outcomes. So I wanted to open the floor to you guys to see what else you guys think about the study.
Um, do you want to go first?
Sure. I think the thing that we were talking about that really stuck out to me is we were talking about how these patients, some of them have, increased ischemic events when we're waiting longer to do the procedure or to do a CABG. But then also, if we don't wait as long after the administration of because obviously, if you stop the ticagrelor or if you stop the antiplatelet and you do not have platelet quiescence, you're more likely to have an ischemic event. Or are they going to be affected by that, or are they going to be affected by this perioperative or bleeding? Obviously, they've shown in this, like you said, small powered study that it's non-inferior and that they don't have more bleeding events, but which would be the thing that's more affected? I think that was the thing that was sticking out to me. And I would like to see how, as we do this in a larger powered study, I think it would be something that's interesting. Because which one is going to affect our patients more and which one actually eventually shows more benefit, I think would be is it what interesting to me. Bron, what else do you think?
So, this is sort of more of like a general thought. It's not necessarily like very specific to the results of this study, but a lot of the current guidelines on when you can safely do an elective CABG post, uh, ticagrelor or clopidogrel administration or any of these antiplatelets that we use, they're all based on retrospective studies. And so the idea of this study, and while it's still small and still just about non-inferiority, this is probably higher quality type of data that we're looking for to then later adjust our guidelines potentially or reinforce the current guidelines that we have. So I think this is like a good step, in that direction. It seems like there is this sort of like push towards doing elective cabbages sooner. And this kind of like older thought of delaying it is maybe falling out of favor, although we don't have like any hard evidence from like a prospective study to back that up and to, like have some, empirical evidence of that. So I think that this is like the first step in doing that. And I think that will be really great to see and will help not just with patient outcomes, but like healthcare utilization and minimizing length of stay for our patients and minimizing them potentially to all the effects of, increased length of stay and things like that without incurring any harm, to our patients. So I think it's interesting. This also could be something to support the use of ticagrelor over other antiplatelet agents, especially, we have no way of knowing if our patients are going to need a CABG at the time of presentation for ACS, but if there's some reason that you might think so because they have known ischemic heart disease, they're high risk for various reasons, that might be your antiplatelet of choice. And then as a result of that, you may be able to feel more comfortable knowing that after you cath them, if you decide that they need CABG, that you're not delaying like definitive treatment of their condition. So.
Yeah, I think there's a study that's ongoing that was reading in this paper that is evaluating if there's a monoclonal antibody that is effective at reversing some of the Brilinta effects as well. So that'd be also interesting. I think it's enrolling patients actively. And then I think what Anisha mentioned about what's better? Are we the decreasing ischemic events or increasing bleeding events? I think that's a really, really hard line to toe across. So it's a balance, and I think as we get more information about what antiplatelets to use in what situations, I think it'll be tailored to that patient and or that condition.
Yeah.
Agreed.
Okay, so our fun question, I don't think any either of us have any more thoughts today. But our fun question for the day is if you could be an animal, what would it be? Um, Bourann, do you want to start?
Um,
And
sure.
why?
I'm
Okay.
trying to think about what I would want to be. Um, I think a bunny. I would want to be a bunny.
Why a bunny?
I don't know, because they like hop and they're cute and I don't know. I don't really have a good answer, but that's just what I feel in my soul connects the
Yeah.
most. Yeah. No further questions. You guys go.
Okay.
I'm good.
Um, I'd like to be a dog. I have a dog right there who's going crazy. So I would want to
Kind
see
of
what goes
dog.
in her head. It's at least half Australian Shepherd. I don't know exactly what the
So
rest
what
of.
kind of dog do you want to be?
Oh, do I want to be?
She's blurry right
She's
now.
blurred anyway, but what kind of dog is a good question. I'll have to get back to
Okay.
you.
You guys can find out in the next episode,
Yeah,
maybe. I think I would be an elephant or a lioness. I don't know. It's one or the other. They both, I think, are part of two parts of my personality. Lioness being me, being a fiery individual and or getting things done, but elephant being the part where I am silly and or remember everything about people. And so, elephants are known to have their not about medicine, let me be clear, but about people and their lives and all that stuff. I love to remember all that stuff and their stories. So I feel like both of those, they're very different, but could both affect
yeah.
my, you know, representation. So
I feel like there was like a clear difference in between how much thought we put into our answers and Anisha's answer.
Yeah, I think she's been sitting on this question for a while.
all right, everybody. Thank you so much for watching I believe our 10th episode of The Heart of the Matter. We will see you next time. Bye.
Yep.